Um, so, how should a practice leader evaluate which revenue cycle management system they should use that'll fit best with their practice?
There are a lot of options, and I think what we have recommended to our members is that they start to look at what they do every day. So what transactions do they conduct? And you think about revenue cycle, it really starts with establishing the patient eligibility for insurance coverage. So that eligibility transaction really kicks everything off. And so if that is done in an efficient way, what you'll find is you don't lose money on the back end. So for example, there are still practices that use the kind of cross your fingers and hope approach to eligibility. So the patient comes in, they write down the insurance number from the card, submit a claim, and then hope that it gets paid. The more advanced practices understand that that's a critical time in the revenue cycle. So many of them do advanced eligibility. So using the X12 270, 271 transaction, they're able to actually find out ahead of the visit whether or not the patient's insurance card is valid. If it's not, it gives the practice opportunity to reach out to the patient to say, it looks like your insurance is no longer valid. Have you switched insurances, or will you be paying cash? And so it allows that dialogue to take place rather than submit the claim, have it denied, and then try to go back after the visit to try to reclaim some of that money from the patient. So that eligibility piece, if you can automate that, it makes everything a lot easier. Then you get into the transactions, for example, the claim itself. Many practices submit claims through a clearinghouse. Some do direct to the health plans, but ultimately, the more you can automate that, the more you can use the X12 837 electronic claim, the faster you're likely to be paid, which again improves the practice's bottom line. Then you get into some of the other transactions, for example, the 276, which is the claim status. A lot of times the practice, when they submit a claim, it literally goes into a black hole. They don't know what's happened to that claim. So using that transaction, it tells the practice, most importantly, that the health plan received it, because what you don't want is to wait 3, 4, 5 weeks, follow up with the health plan, and they claim they never received the claim. So you find out almost immediately. In fact, some practices send the claim status immediately after they send the electronic claim, almost like you're trying to get an acknowledgement from the health plan that they received the claim, which is interesting because there is an acknowledgement transaction available, much like if you bought something from Amazon, the first thing you get is an acknowledgement email saying, we got your order and we'll let you know when it's shipped. Here, the government has dragged its heels and not released a regulation establishing this acknowledgement transaction. So a lot of practices use this claim status inquiry to make sure that the health plan received the claim. Then, once the claim has been paid, then the practice has a number of opportunities, again, to save money. The old style is for the practice to receive a paper check. And then at some point before or after, they'll receive a paper witness advice or explanation of benefits, EOB. So that means a staff member needs to sort of reconcile the two to make sure that they got paid what they were expecting to be paid. And it just takes a lot of time, and there's mistakes made. The new systems, the new software permit the practice to use electronic EFT, electronic funds transfer, meaning that the health plan pays claim from their bank and goes directly to the provider's bank. And then there is a rule that requires that the electronic remittance device, known as the 835 transaction, is sent electronically to the practice, which allows the software to do the reconciliation. It then allows the software to identify potential outlier, maybe a claim that needs to be followed up on. So it cuts the staff time down, increases the accuracy, and ensures that the practice gets paid what it is owed. And then, of course, there is the prior authorization transaction. That one is proven to be one of the most challenging for the industry. There actually is a standard for an electronic transaction. It's known as the 278 transaction. However, it is only used about 12% of the time. And the problem there is that we're missing one transaction, and that is what's known as the attachment transaction, the 275. So if you think about when you would need in the revenue cycle to move health data from the practice to the health plan, it's primarily in two areas. One is the claim. So if you submit a claim and the payer says, we need additional information, additional clinical information in order to pay the claim, then you need to send that to the payer. Or in the case of a prior authorization, the payer in many cases will say, we cannot make a decision until we see, for example, clinical notes. And right now, the only effective way to send that information from the practice to the payer is manually, whether you send it fax, whether you literally copy it, put it in an envelope and mail it to the health plan, or in some cases you can get out of your EHR workflow and go into a proprietary health plan web portal and upload the clinical documentation using that means. All of those are time consuming, certainly not efficient, and cost the practice money. So we're waiting for the government to issue this 275 transaction rule. It was mandated, if you can believe it, in 1996. And it's been that long since the government has been required to issue the rule and has failed to do so. So we, along with many others in the healthcare community, have been pushing CMS, the Centers for Medicare and Medicaid Services, to issue this rule to allow more automation to take place. A long-winded way of saying that there's a lot of steps in the revenue cycle. Most of them now are manual, but certainly most, if not all, could be further automated.